Hello, everyone. Welcome to today's Leveraging Lessons from the Past webinar on What's New in Quality and Regulatory 2025. This is Jenna Peterson, an education specialist for Mayo Clinic Laboratories. Our presenters today are Chelsea Conn, Director of Regulatory Affairs within the Department of Laboratory Medicine and Pathology, and Jenny Nosbisch, a CLIA Compliance Program Manager with the Integrity and Compliance Office. Both presenters are from Mayo Clinic in Rochester, Minnesota. A couple of reminders for everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the Q&A icon in Zoom. Please only use the chat function for any technical issues. Also, today's program is being recorded and will be posted to our website in a few weeks. And now I will turn things over to our presenters.
Thanks, Jenna. Welcome, everyone. We're glad you're able to join us today. Next slide, please. All right, so I'll start us off. This is Jenny. I'll start us off regarding disclosures. Neither Chelsea nor I have any financial disclosures or conflicts of interest to report. Next slide, please. Learning objectives. After this talk today, you should be able to describe the current situation with Clinical Laboratory Improvement Advisory Committee, or CLIAC, and the implications to clinical laboratories. 2, determine operational impact of recent updates to CLIA brochures and memos. 3, be able to summarize the regulatory journey of the FDA's LDT final rule. And 4, describe the shift from unannounced to announced inspections by CAP and AABB. Next slide, please. I'm going to start us off talking about CLIAC, the Clinical Laboratory Improvement Advisory Committee. Next slide, please. So what is CLIAC? CLIAC was a committee established under the Public Health Service Act back in 1992, so 33 years ago. This committee provided scientific and technical advice and guidance to the Secretary and Assistant Secretary of the Department of Health and Human Services, HHS, the Director at CDC, the FDA Commissioner, and the CMS Administrator. This advice and guidance pertain to issues related to improvement in clinical laboratory quality and lab medicine, including suggested revisions or modifications to the CLIA regulations, as well as clarity on issues. As we all know, advances in technology can cause ambiguity with regulations that are seldom updated. The committee would develop recommendations for either CMS, FDA, or CDC. The 3-letter organizations would take those recommendations and either act on them or not. The CLIAC website used to have a table where with their recommendations, and it showed where each recommendation was in the process, if it resulted in any changes, and things like that. These meetings and recommendations provided a good insight into what would be coming. For instance, topics or clarifications we would see in future CMS memos or even updates to the CLIA regulations. Think about recent changes with proficiency testing, personnel, histocompatibility, all great examples of topics that were discussed at previous CLIAC meetings, but now we've seen changes actually in the regulations. The CLIAC played a vital role in advancing regulatory updates. They met twice a year, and the public was able to register and listen in on the meetings. As a group, they were very transparent. All presentations that were given at the meeting were available on their website. They kept good meeting minutes, which were also available on their website. Membership was made up of roughly 20 individuals, including lab and medical professionals and other interested parties, each serving rotating terms. It also included representatives from CMS, FDA, and the CDC. Next slide, please. So what happened to CLIAC? You probably picked up on the fact that I have been using past tense verbiage. Well, on March 31st of this year, CLIAC was terminated by the CDC. Their website has been minimalized, yet still contains some information. So how does the elimination of CLIAC impact us in the laboratory community? I can think of a few different ways. One, we, and more specifically pathologists, have lost an avenue to collaborate with federal regulators and each other to address issues laboratories are facing. Two, we lost an insight into what was coming through the pipeline. We also lost sight of upcoming changes to regulations, as well as lost insight to areas regulators were placing focused attention on. And in addition, losing CLIAC affects our ability to impact future regulatory changes. And lastly, we've lost an advocacy channel. So what's next? Advocacy, advocacy, advocacy. Right now, there is no CLIAC, but there is a possibility of it being overturned because there is a ton of advocacy going on right now. Next slide, please. So next, I will talk about updated CLIA brochures and updated CLIA memos. Next slide, please. All right. We've seen quite a few CLIA regulatory changes over the last few years, such as proficiency testing, histocompatibility, personnel requirements, alternative sanctions, CLIA fees, to name a few. These were actual changes in the CLIA regulations, and we've discussed them at past webinars. These changes have a ripple effect, though, for a few years after those regulatory changes are put into effect. CMS updates CLIA brochures and publishes memos to keep clarifying what was actually updated within the regulations. The brochures and memos give us golden nuggets of information on what they mean by the regulations and give us insight into what they expect compliance to look like. These types of documents, brochures and memos, are available for everyone on the internet. Today, I'll touch on recent updates to CLIA brochures and memos. There's been quite a few changes lately, or updates. I'm going to start out discussing updated CLIA brochures. I'll cover a total of 5 brochures today. All have been updated into a new, easy-to-read question and answer format. The brochures are available on the CMS CLIA website and are good reference documents. They contain those key nuggets of information. The information within the brochures is not intended to replace or substitute the CLIA regulations or any other statutes, regulations, or formal policy guidance upon which these brochures are based on. Consider it a general information summary. It summarizes current policy and operations as of the date it was published. The first one covers proficiency testing and PT referral. This brochure was revised a year ago in October of 2024. It goes hand in hand with CLIA memo QSO-24-15-CLIA, which was the final rule of CLIA proficiency testing and acceptable performance. That document came out in July of 2024. And this new one incorporates information from that memo and from the final rule updating the CLIA PT regulations from back in 2022. The brochure is easy to read, and it's in a new format, the question and answer format I mentioned. All of the updated brochures I'm going to talk about today are in the new easy-to-read question and answer format. Interesting caveat. Within this document, CMS points out that this brochure specifically only applies to CMS inspected labs, so labs with the CLIA certificate of compliance. The information within the brochure may not apply to accredited labs or cytology PT, specifically because state, local, and accreditation requirements may be more stringent. Next slide, please. In May of this year, CMS released a brochure titled CLIA Certification. This one provides a great overview of CLIA basics in that question and answer format. It covers how to apply for a CLIA certificate, it defines CLIA, and it does a really good job explaining CLIA exceptions. It discusses test complexity and CLIA certificate types. It touches some on accreditation too. It has a nicely laid out table explaining how to maintain your CLIA certificate. It's a great overview. Next slide, please. The next brochure is on laboratory complaints. This is another one that provides a pretty good overview. This brochure was revised in May of 2025, so this year, and dives into everything about complaints. It covers the who, what, when, where, and how elements. It covers everything from how to file a complaint to what to expect after a complaint is filed. It provides details on what to include in the complaint, and it gives information on who can file a complaint and the how of actual filing complaints. It nicely explains what to include in a complaint and what happens after the complaint is filed. It's a short but mighty document. Next slide, please. The next updated brochure is Assessing Personnel Competency. Again, this one was revised in May of 2025, so just this year, and is based off the 2023 and 2024 updates to CLIA on personnel competency. This one describes key procedures needed for a laboratory compliance assessment. It explains how to assess and document laboratory personnel competency based on CLIA-defined roles and testing complexity. I'll cover a few key takeaways from this one. For laboratories performing provider-performed microscopy, so PPM testing, if the PPM testing is being performed under a CLIA PPM certificate, the CLIA lab director is responsible for evaluating the competency assessment for all testing personnel. That's what the regulations say. However, the lab director may delegate in writing the responsibility of competency to other qualified PPM testing personnel. That's not in the regulations, but that is in the brochure. PPM testing can also be performed under a CLIA certificate of compliance or a CLIA certificate of accreditation. If this is occurring, the technical supervisor can perform and document the competency assessments or can delegate this responsibility in writing to the general supervisor as long as they meet the regulatory qualification requirements. Also, this document clarifies that PPM competency assessments only need to include 5 of the 6 procedures in a competency assessment. So directly observing instrument performance, maintenance, and function checks don't apply to PPM competency. This brochure has a table that highlights items you should consider when assessing personnel competency by role, including delegated responsibilities. Assessing laboratory personnel competency or the ability to correctly apply their skill, knowledge, training, and experience to their laboratory duties is an important part of complying with CLIA regulations. Next slide, please. This brochure, so the next brochure, focuses specifically on laboratory director responsibilities for moderate and high complexity laboratories. It covers everything from what the CLIA lab director overall responsibilities are to the role a quality system plays. It describes the specific duties of the CLIA lab director and what the required personnel positions are for each CLIA type. It provides the top 10 tips laboratory directors should consider. What I really like about this brochure is that it lists out the required laboratory director duties that can be delegated to individuals in other roles. That wraps up the information I have on updated CLIA brochures. I'm now going to move to CLIA memos. Next slide, please. The first memo I'm going to cover is QSO-25-21-CLIA, which was released on June 23rd of this year, 2025. It's titled CLIA Enforcement Discretion and Clarification on Personnel Regulations. I know you won't remember the QSO number, but I want you to have them on the slide so you, after today, you can look it up. Find it when you need it and want it. A hint, the first number after the QSO indicates the year the memo was released. So this one is QSO 25, indicating it was released in 2025. This memo was a direct response to the latest CLIA personnel qualification regulations that went into effect in December of 2024. Since then, CMS received stakeholder feedback that some of the new personnel qualification regulations were either unclear or burdensome. Because of this, CMS will be exercising enforcement discretion in a few circumstances. And this memo spells those out. So a couple of what I'll highlight here is enforcement discretion of personnel regulations. CMS will be exercising enforcement discretion in a few limited circumstances with respect to certain regulatory personnel qualification requirements. CMS will allow laboratory directors qualifying under 493.1405B2, that's the laboratory director for moderate complexity testing, to have either at least 1 year of experience directing or supervising non-waived laboratory testing, or 20 continuing education credit hours in laboratory director responsibilities. Another one, CMS will not require the additional 20 CE credit hours currently required under 493.1405. And there's a few of those 1405 qualification requirements. And then also the ones under 493.1443. The 493.1405 is the lab director qualifications for moderate complexity testing. And the 493.1443 is the laboratory director qualifications for high complexity testing. As such, any individual previously qualified as a clinical consultant will be able to continue to qualify without taking any additional 20 CE credits. CMS will allow for individuals qualified as technical supervisors under 493.1449 to qualify as high complexity laboratory directors for testing in dermatopathology. The memo also clarifies a few other personnel regulations. One is clarification of moderate and high complexity laboratory director qualifications. The clarifications state an approved thesis or research project related to laboratory testing for the diagnosis, prevention, or treatment of any disease or impairment of, or the assessment of the health of human beings as required under 493.1405 and 1443 and 1449. So there's a few of them. Does not need to be on human subjects, as most research is performed on animal models. Again, only applies to that thesis or research project. Other experience and things like that do need to be on human subjects, not research. So here it's just clarifying the requirement on the thesis or research project. for qualifications. The second clarification is for high complexity laboratory director qualifications. The clarification is the requirements under 493.1443 B3 little 3 for high complexity laboratory directors to require a total of 2, not 4 years of laboratory training or experience, and laboratory experience directing or supervising high complexity testing. CMS plans to address these changes in future notice and comment rulemaking. So hopefully we'll see that in the future. I also want to point out that this information is specific to CLIA. If you are an accredited laboratory, please check your accreditation program standards. CMS may be exercising enforcement discretion, but your accrediting agency may not be. So important to check with them. Next slide, please. The next memo is on CLIA applicability for laboratory testing associated with blood, cells, tissue, and organs. The last CLIA memo on this topic was from back in 2011. This was a long overdue update. It was kind of a hot topic in the world. The scope of this document is limited to testing associated with blood, cells, tissue, and organs for transfusion, implantation, transplantation, or infusion. This document contains a table that lists the type of specimen being tested, the test, and a yes or no if CLIA applies in that specific situation. The table is wonderful. The basis for determining CLIA applicability is the CLIA definition of a laboratory. So the definition taken straight out of the CLIA regulations. If the entity conducting the testing in question qualifies as a laboratory under the CLIA definition at the time the testing in question is being conducted, the test is subject to CLIA. This document clarifies that testing on a potential donor, so brain or circulatory death, is subject to the CLIA regulations. Perfusate specimens from isolated in vivo or ex vivo organs for transplant are not considered a specimen derived from the human body, and therefore testing on these specimens is not subject to the CLIA regulations at this time. This document does not address testing performed on recipients of these donation types. If this testing applies to your laboratory, I highly suggest looking at this document and paying attention to the table within the document. It's very helpful. Next slide, please. All right, the Medicare State Operations Manual. Before I get to the next two memos, I want to take a few minutes to talk about the Medicare State Operations Manual. I have provided a link at the end of the slide deck for your reference. The State Operations Manual, or SOM, S-O-M is how it's abbreviated, is a document issued by CMS that provides guidance for surveyors. It's a reference document for healthcare institutions to navigate compliance audits, find policies, procedures, regulations, and really to prepare for surveys. It's an essential tool for various healthcare settings to ensure they meet the minimum health and safety standards required to participate in Medicare and Medicaid programs. It includes chapters covering various healthcare settings, such as skilled nursing facilities, hospitals, laboratories, and home health, and is a key part of the CMS certification process that determines eligibility to participate in CMS reimbursement programs. There are 3 areas of importance that I want to point out today specific to labs. The first is the SOM appendix section, the one the top arrow is pointing at on the slide. When you click on that, within the appendix section are numerous appendices. I actually think that's from A to Z from an appendices perspective. The one impacting labs is Appendix C. So this one is specific for laboratories and is referred to as the CLIA interpretive guidelines. So I'm going to talk about that one in a few minutes. Another area of focus for laboratories within the Medicare State Operations Manual is Chapter 5, that covers complaints. And then Chapter 6, which is the special procedures for laboratories. And I'll talk about that one in a little bit, in a few more minutes as well. Next slide, please. Okay, Memo QSO-25-10-CLIA revised is the latest State Operations Manual Appendix C, which is titled Survey Procedures and Interpretive Guidelines for Laboratories and Laboratory Services, CLIA. For short, it is known as the CLIA Interpretive Guidelines. This is one of those documents that we see updated on occasion. It's not on a yearly basis, but every few years we'll see it updated. The updates are made to incorporate information from previously released memos, clarifying confusing topics in CLIA, and or updates to the CLIA regulations. So all of those things kind of accumulate to update this document. This latest version revises the December 6th, 2024 version of the CLIA interpretive guidelines. So they put one out back in December and they've since updated it again, just with more clarifying information. The interpretive guidelines are arranged by CLIA regulation number. The latest version also inactivated 3 previous versions of the interpretive guidelines. Basically, they were cleaning up documentation to just reduce confusion. There is previous versions of this document still out there available. The information from those previous versions have all been incorporated into this latest version. They also expired 2 previous memos specific for personnel policies and incorporated that information within these interpretive guidelines. So the 2 memos that expired were SNC 16-18-CLIA, so from 2016, which covered personnel policies for individuals directing or performing non-wave testing, and SNC 10-7-CLIA, which was titled Consolidation of Personnel Policies for individuals directing or performing non-wave testing under CLIA. As you can see by the titles of those documents and the fact that CLIA personnel regulations were recently updated, you can see why those 2 previously released memos were expired. So a few details of what is in the updated document. This latest version incorporates the 2022 updated proficiency testing regulations and the 2023 updates to CLIA certificate fees, updates to histocompatibility, alternative sanctions, and personnel requirements, just to name a few. They added the United Council for Neurologic Subspecialties, the UCNS, as an approved HHS training program for neuromuscular pathology. They incorporated feedback and addressed frequently asked questions within the document. For example, many stakeholders had concerns regarding competency assessments needing to be in person for direct observation, considering technology that allows virtual observations. So for the technical consultant and technical supervisor responsibilities and the PPM CLIA lab director responsibilities sections, they have removed the in-person wording from direct observation. In addition, stakeholders had concerns that nursing degrees would no longer meet the educational requirements under the high complexity testing personnel regulations under 493.1489B. Specifically, their concerns were that individuals with nursing degrees would no longer meet the educational requirements under the high complexity testing personnel regulations to perform the patient bedside glucometer tests that fall under the CLIA high complexity test categorization. So CMS will be adding the following guidance on nursing degrees in the final publication. limited exception to allow qualified individuals with a bachelor's of nursing degree to perform high complexity glucometer testing. They added the new terminology and included additional information for each of those terms within the document. So for example, they explained what is acceptable and expected as experience directing and supervising. That is one of those terms they defined. They also removed a whole section. They removed all of the survey protocols, so information that was specific to surveyors regarding the actual surveying process have been removed from the interpretive guidelines, so from Appendix C. And they've actually been moved over to that Chapter 6, Special Procedures for the Laboratory. They give examples of what is acceptable for a doctoral degree, just a few examples of things that they've added and changed in this interpretive guideline. I highly recommend you get familiar with Appendix C, the interpretive guidelines. It has a ton of valuable information on what is expected for labs. It gives us in the lab an inside view of how CMS expects the CLIA regulations to be interpreted. It clears up some of the gray. Next slide, please. Okay, on September 12th, so not that long ago, QSO 2510-CLIA, Appendix C, Interpretive Guidelines, the one I was just talking about on the last slide, went from an advanced copy to a final copy. So it may be confusing if you search, you see two different ones out there, but that's the difference. One went from advanced to a final. It's semantics for the most part. Pretty minimal changes between advanced and final. The final copy includes an effective and implementation date under each section, so you can kind of see in red there. And it's a nice feature of this document. It's that it includes updates in red, so you can easily see what has changed. Word of caution, be aware that the CMS CLIA website still lists an older version. Actually, the version on the website is from 2017. A few updates have been missed, haven't been updated on that website. So just search the internet for this latest QSO memo, or you can even search for CMS R233 SOMA to find the finalized version. Next slide, please. Okay, next is the sister memo. So this is QSO 25-13-CLIA. It's a revision to the State Operations Manual, Chapter 6, Special Procedures for Laboratories. You can find it by either searching the QSO 2513-CLIA or CMS R230 SOMA. As I said, this is a sister document to the interpretive guidelines. This one is not arranged by the CLIA regulation number. This one is more topic-based and focused on the survey process and responsibilities of the surveyor. For instance, within this document is section 6009, titled Multiple CLIA Certificates at the Same Location. It gives information for the inspector specific to this topic. Sometimes it references the actual CLIA regulations, but not always. I bring this one to you more for informational only, and hopefully to add some clarity on two different memos with pretty similar names. This latest memo also expired the previous version of this document, which was SNC 19-20-CLIA. Next slide, please. This is the latest memo that I've seen. It is QSO 23-15- So it's the CLIA, Clinical Laboratory Improvement Amendments, CLIA Post-Public Health Emergency Guidance. Yes, it's 2025, and I just mentioned the PHE. It seems as if CMS is cleaning up older, outdated memos and closing loopholes still in place since the PHE. This memo was released on September 23rd, just a couple weeks ago. A couple hot topics covered by this memo include that CMS is discontinuing the temporary exercise of enforcement discretion that previously allowed remote review of cytology digital slides at locations separate from the primary CLIA certificate cytology laboratory. It is effective 6 months from the date of this revised memo. So March, I think, if I do my math right, March of 2026. Laboratories currently reviewing digital images of cytology slides at a remote location and wanting to continue this practice will need to obtain a CLIA certificate for the remote location within 6 months of the publication of this memo. The CLIA statute for cytology requires all cytology screening be evaluated on the premises of a laboratory certified to conduct testing in the subspecialty of cytology. Because of this, they are removing the temporary exercise of enforcement discretion that was given during the PAG. The other topic covered by this memo is that the temporary exercise of enforcement discretion related to the iStat CTNL, the cardiac troponin test cartridge, for moderate to complexity testing or tests will cease on March 30th, 2026. That's the end of my slides on CLIA memos, but I have one more slide for you. Next slide, please. Attention, attention, read all about it. In case you haven't heard, CLIA is going electronic. No more paper CLIA certificates or invoices, or as CMS calls them, feed coupons. No more lost mail. That's what I like best about being electronic. CMS is switching to only electronic notifications. You must switch to electronic email notifications by March 1st, 2026. CMS will stop mailing paper versions after this date. So action is needed. There are 3 ways you can switch to electronic notifications. First, you can send an email to your state agency. Nothing fancy, just an email stating, for this CLIA number, please send electronic notifications to, and provide them an email address. The second way, if you're an accredited laboratory, is to contact your accreditation organization. They will make the change on your behalf. The third way is to fill out a CMS 116 form. And when you fill that out, check the receive notifications, including electronic certificates via email box. To my knowledge, you can only list one person to receive the electronic notifications. If someone knows otherwise, please let me know. That's the end of my slides, and I'm going to turn it back to Chelsea to talk about PAMA.
Thank you, Jenny. One of the topics, like Jenny said, we wanted to make sure to cover was a brief reimbursement update on PAMA reform and what is happening with that. So to provide some background on PAMA, this was enacted in 2014 to modernize Medicare's clinical laboratory fee schedule by tying reimbursement to private payer rates. And since then, over 75% of those CLFS codes have seen reductions. Data collection was really a very narrow sampling. It really only captured like large laboratories, large reference labs, and excluded several hospital and physician labs that really represent a large portion of Medicare spending. And without some kind of successful change to this, we could be seeing cuts of up to 15% scheduled to start at the first of next year. So there was a new bipartisan legislation that was introduced at the end of September called the Results Act. And before I get into that, if you recall, SALSA is what existed before. So this was filed in 2022 and 2023, and that was known as the Saving Access to Laboratory Services Act. However, due to SALSA's complexity and the potential cost to carry that out, labs and industry are starting new with this Results Act. So the Results Act stands for the Reforming and Enhancing Sustainable Updates to Laboratory Testing Services. The legislation caps annual rate cuts at 5%. It requires CMS to use a statistically validated sample of all lab types, so not focusing on just the large ones. There would be a reduced reporting frequency from 3 years to 4 years. It excludes Medicaid managed care rates and allows exclusion of manual remittances under 10%. The legislation is very supported by several industry and trade organizations. And overall, it really aims to protect lab quality and reduce that administrative burden. These groups are very hopeful that the act gets passed before the end of the year, but it definitely faces obstacles right now with the current government shutdown. And so another topic we wanted to make sure to cover was the journey of the FDA's LDT rule and where that officially stands as of today. So while FDA regulation of LDTs has been talked about for a very long time, it was May 6th, 2024, when FDA published a final rule that would in fact regulate laboratory developed tests as medical devices. It was a phased or staged process that would roll out over the course of 4 to 5 years. Stage 1 was focused on the lab's meeting requirements for medical device reporting, complaint files, and correction and removal reporting. Stage 2 was going to require LDT manufacturers or laboratories to register and list their tests. And then labs would also need to meet certain labeling requirements. Stage 3 was going to see further quality management system requirements, and those were specific to records, CAPA, corrective action, preventive action, purchasing controls, design controls, and acceptance activities. And then finally, in stages 4 and 5, FDA was requiring labs to meet pre-market review requirements on top of all of the other previous stage requirements. Now, while many organizations were preparing to get ready for that stage 1, at the very least, the American Clinical Laboratory Association and Association for Molecular Pathology filed a joint lawsuit against the FDA in 2024. In February 2025, a district court judge in Texas heard oral arguments. And then we learned on March 31st, 2025, so this was just a little over a month before that rule was set to start rolling out and take effect, that the judge vacated the rule in its entirety. The judge agreed with ACLA and AMP, stating that LDTs are not devices, that they are services, and that FDA does not have the statutory authority to regulate LDTs. The FDA was given 60 days to appeal, and FDA does not appeal that ruling. On August 6th, 2025, the Office of Information and Regulatory Affairs published a notice that the FDA rescinded the LDT final rule. And then finally, just about a month ago, September 19th, the FDA issued a final rule reverting to the text of the regulation as it existed prior to that May 2024 effective date. So what does this mean for laboratories now? Well, as it stands today, FDA cannot and will not regulate LDTs. There is still enforcement authority over those companies manufacturing specimen collection kits, analyte-specific reagents, and research use only products. So it did not affect the regulations specific to those. And then we just wanted to make mention that laboratories cannot become complacent. It's very important to stay up to date on the news related to lab regulations and standards. We know that's always changing. We could see legislation in the future that maybe reshapes CLIA or something completely different. We're in that unknown phase at this point. Either way, we know this topic will continue to be part of the lab world for years to come. So this is not the last time we'll hear about this or probably talk about it. And then shifting gears a little bit over to a new development with CAP and ABB that was announced this summer. So this was effective on May 20th of this year. The College of American Pathologists and Joint Commission revised their agreement permitting advance notice of lab inspections at Joint Commission accredited hospitals. So labs will now be notified of their inspection date 2 weeks prior to the inspection. This announcement does not have any effect on the lab's current 3-month inspection window, so that should not change your organization's timing for that. And then unannounced inspections will continue based on complaints or follow-up inspections due to previously identified noncompliance. And then also on the CAP subject, there was a new CAP checklist requirement that was added during the last set of checklist updates. So if you recall, this was in December of 2024. The requirement we want to focus on for this presentation is the new reportable disease reporting requirements. So while many laboratories are likely already well-versed in the legal obligations to report certain diseases and conditions to their state health departments, we'd like to offer some additional context around the new CAP requirement. So on this slide here, this is a very abbreviated table. However, we wanted to share some background on what's expected today at the local, state, and federal or national level. Healthcare providers and laboratories are required to report, and several diseases must be reported, especially those posing significant health threats. The time frame varies by disease and jurisdiction when reporting. Typically, healthcare providers or labs are required to report within 24 hours up to a week. Again, the answer is really, it depends. Why do we do this? This is a legal requirement. We need to be able to monitor disease spread, detect outbreaks, and support public health interventions. And reporting mechanisms may vary. It's typically done electronically, but you might have to place a phone call as well. Again, this is going to depend on the state and jurisdiction in which you're reporting. So now, knowing that these requirements have actually been incorporated into the CAP Lab General Checklist, specifically Gen.41318, and it's titled Reporting and Submission of Materials to Public Health Authorities. It's stating that the laboratory ensures there's a mechanism in place to report test results and submit materials to public health authorities if required by national, federal, state, and local laws. And the goal of this new checklist requirement is to separate the reporting to public health authorities from the reporting to clinical personnel. So if you're familiar with the Lab General Checklist, the specific one I'm referring to is Gen.41316. This is the significant infectious disease diagnoses. That's where the clinical personnel reporting is captured. So now there's the separate one for reporting to public health authorities. And it's important for labs to keep up to date on the applicable reportable disease regulations, as they often change and they are different for every state. And so another piece of this checklist requirement is that CAP recommends performing at least an annual review to stay current on those different state regulations. And that is the end of my slide deck. Are there any questions?
Yes, thank you, Jenny and Chelsea, for your great presentation. Like Chelsea said, we would like to take any questions that you might have, and you can submit those questions using the Q&A icon in Zoom. And we'll give it a couple minutes to see if we have any questions come up.
Okay, so the question was, I have seen info circulating about a new requirement for proof of previous work history via competency documents or letters from previous employers rather than using a CV or resume. Does this apply to all CLIA roles and to staff that are already employed? So in the latest updates to CLIA, they added a new term, and that was laboratory training or experience. It's kind of many words, but one thought there, laboratory training or experience. They clarified what this means and what is expected in the latest version of the CLIA interpretive guidelines. Under the term laboratory training or experience, it says documentation may consist of, but is not limited to, the following: letters from training programs or employers, attestation statements of an individual's training and experience by the lab director, log sheets initialed by the individual indicating attendance at a training session or in service, and certificates from organizations providing training sessions, workshops, conferences, and special courses. It also says all documentation supporting an individual's education, training, and experience must be generated by an individual other than the person attempting to meet the CLIA personnel qualification requirements. So that's your answer. For example, a CV is not an acceptable verification in and of itself to document an individual's education, training, or experience. They go on to say letters on letterhead from previous employment, competency assessment, and a comprehensive list of job responsibilities may be examples of acceptable documentation. Regarding if this applies to all CLIA roles and staff already employed, it would apply to any role or qualification that requires laboratory training and experience, that term that they're using. I haven't seen anything clarifying this, but usually it's from the point forward and not retroactive. So the question was, back to the original question about if it's staff, if staff already employed, if it applies to them as well. Usually we see it going forward, not retroactive.
Can CMS accrediting agencies inspect nearby patient draw locations? So no testing's happening here. That send samples to the lab being inspected. The draw location has a different address than the lab. If yes, then is the lab director responsible for all collection locations? Examples include physician office, LTC, question mark. Okay. So again, I think the answer for this is really, it depends, which I know we don't love that answer. But the response to this is highly dependent on specific circumstances and can really vary based on different factors. So whomever had asked this question, for the most accurate and relevant guidance, I really recommend that you reach out directly to the accrediting organization by which you're currently accredited or whom you intend to seek accreditation from.
I'm not seeing any other questions come in, so I want to thank everyone again for participating in today's Leveraging Lessons from the Past webinar on What's New in Quality and Regulatory 2025. If your question was not addressed during today's session, or if you have additional questions, please include them in your evaluation, and you may reference the link in the chat to access that evaluation now. Laboratory credit is extended for this program. Upon finalizing your evaluation, you will have the option to claim credit and print your certificate. And as a reminder, this program was recorded and will be archived on our website in a few weeks. Thank you again for joining today's webinar and have a great day.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.